So next I want to introduce Monica Baskin. She is the leader of the Jefferson County Place Matters team. She's a professor in the Division of Preventive Medicine at UAB School of Medicine and has other appointments, Department of Nutrition Sciences, UAB School of Health Professions. She also holds appointments in the UAB Minority Health and Research Center, UAB Comprehensive Cancer Center, UAB Nutrition Obesity Research Center, and UAB Diabetes Research and Training Center. It's a lot of centers. She has a degree in psychology and sociology from Emory University, a Master of Science in Community Counseling, and a PhD in counseling psychology from Georgia State. She's a licensed psychologist. A lot of her research focuses on minority health and health disparities. And that's one reason she's here today, is to help guide us along those lines, because as you have seen and will see, disparities is a big part of what we're going to be focusing on. Monica.
So thank you very much for the opportunity to come. And I think primarily what I wanted to do is kind of remind you guys, around this time last year, I came before and talked about a health equity report that the Jefferson County Place Matters team had released last fall. Tell you a little bit about what we've been doing and hopefully give you some insights into where we hope all of you guys can help us as we move forward. So just in general, for those of you who are not familiar, Place Matters is actually a national initiative that is with the National Collaborative for Health Equity out of Washington, D.C., and it's really focused on this idea of addressing social determinants of health as a way to promote health equity. So our team is one of 19 teams that include 27 jurisdictions. So there are representative Place Matters teams throughout the country. And again, they're focused in areas where there are higher disparities between certain types of groups. So whether or not that's along racial ethnic lines or even socioeconomic status, the idea is that everyone should have the opportunity to lead a healthy, happy life. So here in Jefferson County, we're really rooted in the idea of leveraging the history here in our community around civic engagement and empowerment. And so we hope to do that by really illuminating the discussions around policies and environmental change by using research, analysis, dissemination, and getting information out. We also are focused on increasing capacity of individuals who are leaders to really be empowered in order to create action and change within their community, and then also to facilitate community action planning. So again, as a brief reminder, this fall of last year, we produced and distributed a health equity report that was really looking at the last 50 years and trying to address the issues of where we stood 50 years after the major civil rights events in 1963 as it related to health and health equity. There are a couple of things that I'll highlight in terms of the summary from the report. One of the things that we noted was that there is significant variation in the county related to racial concentration, poverty, life expectancy, infant mortality, access to healthy, affordable foods, and that was one of the main findings that we had. We also, when looking at the different disparities that existed by place, we noticed that there were certain communities and census tracts in general that tended to have better outcomes, and those tended to center around the Over the Mountain area, the Trustfield areas, as compared to those who were more census tracts that were more central to inside the Birmingham city limits and around the I-20-59 corridor. So essentially, one of the things that we really noted was that place does matter in terms of one's health. In addition, what the report highlighted was that we saw what appears to be some patterns between these poor health outcomes and limited access to health promoting areas and where people live. And that this might have been related to things like zoning and planning, interstate highway development, as well as urban renewal. So again, at the end of the day, the report really shows through a series of maps and graphs and so forth that again, place does matter for health. So over the last year, what we've done primarily is focused on the central theme of your zip code may be as relevant or as important to your health as your genetic code, and really focusing in on those, again, social determinants of health. So what you have access to in your neighborhood, where you live, those kinds of things really do dramatically make a difference in terms of who lives longer, how healthy you are, and who gets sick. So we, similar to a lot of the conversations here, we embarked on a process of trying to really engage our stakeholders, and here we're talking about primarily everyday citizens that live throughout the area. And so we wanted to figure out, based on the report and the review, well, what are the main things that strike you, and where do you want us to focus our attention in the coming months and years? And these were the 3 priority areas that our stakeholders really said to us. And again, a lot of this you will see is a replication of some of the things that have been already presented. So they highlighted, for example, healthy food access was really important, and it was really start to see, where people were able to get healthy, affordable foods and the places that they were not. The second one was infant mortality, and looking at the differences between, for example, infant mortality both in the county being much higher than it is in the state as well as the country, but also looking at racial and ethnic disparities in that area. And then lastly, they wanted to focus on and thought was important was Black male life expectancy. So here's just a few things that maybe highlights some of what they were talking about. So for example, the report highlighted for healthy food access, and by healthy food access, we're using a USDA definition of a food desert being a place in which at least 500 people or 33% of the population lives more than a mile away from a grocery store or large grocery store or supermarket. And so in the county, 41 out of 147 census tracts, in fact, were considered to be food deserts, and those were primarily located in minority communities and low-income communities. And so this is, again, one of the maps in the report. It really shows you graphically where some of that distribution lies in terms of the blue dots on the maps really tell you the population that identifies themselves as Black or African American. The red dots identifying individuals who are considered to be white, green, Hispanic, and yellow is Asian. And then the overlay of the yellow there are where the food deserts as identified by the USDA are located. And so you can see, again, there's some patterns that look to be very consistent with certain communities have access and certain ones don't. So the next thing that we were focused on, again, infant mortality. And so the definition for infant mortality is being used as sort of the death of a baby before they turn 1. And so in 2010, what our data sort of highlights is that infant mortality rate for the state was 8.7, but in our county, the infant mortality rate was 10.8 per 1,000 live births. So again, we're not doing as well as the state as a whole. And then when you look at the racial and ethnic disparities, you'll see an even greater disparity there, where African American babies are about 2.5 times more likely to die before they turn 1 than white babies. And graphically, again, in terms of place matters, this is one of the analysis that we were able to do to sort of see who is at greatest risk. So the colors that are there, and sort of the reds and oranges, really identify individuals that are at substantial increased risk beyond what you would think in an average area. And the blues there represent those people who are having much better outcomes than you would expect if everything is sort of on a normal curve, if you will. And then lastly, the life expectancy issue as a priority. And here we're talking about, at birth. Life expectancy is defined as at birth, the number of years a newborn infant would live if the patterns of mortality at that particular time of their birth were to stay throughout their life. And so, good news is that, most of us will live to about 75.4 on average, but you can see from the graph on the right that sort of varies. So you go from a low of African American males being around 69.1 to a high of 76.7 for white females. And so again, our stakeholders really said, what's going on with Black males, we need to focus on that. And I think a lot of what's happening in the larger community over the last couple of months also highlights some of the other issues that are related to African American men and needing to address those as well. And this is, again, just the same kind of analysis, trying to look at where is the increased risk. And again, you can kind of see some very similar patterns of certain communities where there are greater resources, more health promoting activities and things to be found versus others. So then what are our next steps? So for the better part of this year, what we've done is we've gone around and we've spoken to a number of leaders, government officials. We've had several presentations through city government and county government and so forth, and trying to educate and bring awareness to some of the issues that exist, and even identify some potential policies that may help to mitigate some of the things that we're talking about. And we've also talked at some length to leaders in the community, from the business community and others. And what we've started to do and what we intend to continue mostly throughout 2015 is really going back and engaging those members of the community and taking these materials that we have now condensed into more user-friendly lay materials like infographics and so forth, to go out and continue to disseminate the findings, but more importantly, move to the community action planning when we want individuals to say, this is my community, these are the strategies that I want to employ or I think that may be successful in actually bringing about change. So it's more than just pointing out, here are the problems. We want to engage individuals in coming up with the solutions. And then similarly, we want to identify, what are some existing programs and projects that exist that we can incorporate this in. And as again, you can see some of these priority areas are very similar to things that we've already talked about. But we also want to look at what are some other funding mechanisms to sustain and create new programs. And then lastly, we want to really capitalize on a movement of sorts around this idea of promotion of health in all policies, and really focus in on some of the things that we think might have contributed to some of these place-based disparities, and making sure that we can help to keep those from happening in the future. So one such example is that we're currently working with the Birmingham City Council to get approved a group of us to go in and really carve through the comprehensive plan that the city released around the same time as our report, and make sure that health and health equity are really part of that implementation and monitoring of the plan. So just lastly, I think the work that we have ahead of us, and I include all of us in this room in this work related to health equity. There are a few quick challenges that I think we all should be mindful of. The first one is, this idea of some individuals have better circumstances than the others, and how do you engage people who are in that better circumstance into doing work for those who are not. And that is particularly challenging in our culture. And one such idea, even if you take aside the whole altruistic, we need to do everything in the common good, there's a financial cost associated with the health disparities that we're talking about. And so that's a cost that each of us pays, whether or not it's in increased taxes or increased premiums for our own health insurance and so forth. But this type of disparity is a $1 trillion expense when we think about it nationally. And then even here in Alabama, about close to $19 billion is spent on things that are really associated with the differences between people who get better health outcomes than those who don't. The second challenge, I think, is about what our language is and what we're really talking about. So this particular cartoon talks about this difference between equity and equality. And so equality is really about give everybody the same thing and we're good. But that may not be helpful to the person who's too short to see over the fence, and it may not have even given the other person any other advantage. They could have done it anyway. So what our Place Matters team is really focused on is the equity, meeting people where they are and giving them what they need to be successful so everyone is successful. And then lastly, it's about how do we engage and how do we move into public health of the next century. And so what we're talking about is engaging new people to the table, not just speaking only with people who are from public health. Very much what the Health Action Partnership is about, what Bold Goals is about, is not just preaching to the choir, if you will, but getting those who are not readily engaged in the process to be a part of it. And for our Place Matters work, it's really about the grassroots, making sure that the people who are not necessarily in these rooms and in these organizations, making sure that their voice is heard and they're part of the solution as well. So just leaving off to, acknowledge a number of people that have continued to support our work. Again, the full report is available and still up on our website. And I think I'll stop there.